Welcome, everyone. Today we're delving into the intricate world of rheumatoid arthritis, a complex autoimmune disorder that wreaks havoc on the joints. Rheumatoid arthritis presents a unique challenge due to its chronic nature and autoimmune mechanisms, often manifesting in a symmetrical pattern across joints. To truly comprehend rheumatoid arthritis, it's imperative to juxtapose it with osteoarthritis, the most prevalent form of joint degeneration. By analyzing the distinguishing features of these two conditions side by side, we can gain a comprehensive understanding of rheumatoid arthritis's multifaceted presentation. Throughout this presentation, we'll explore the key attributes of rheumatoid arthritis and its contrast with osteoarthritis, providing valuable insights into diagnosis, management, and the broader implications for patient care. Let's embark on this journey to unravel the complexities of rheumatoid arthritis and enhance our clinical knowledge. Let's explore the concepts of symmetry and inflammation in rheumatoid arthritis compared to osteoarthritis. Symmetrical joints. One of the hallmarks of rheumatoid arthritis is the symmetrical involvement of joints, contrasting with the asymmetrical pattern typical of osteoarthritis. This symmetrical distribution is a key diagnostic feature that distinguishes rheumatoid arthritis from other forms of asymmetrical arthritis, such as seronegative spondyloarthropathy, gout, and pseudogout. Inflammatory process. Rheumatoid arthritis is fundamentally an inflammatory disorder, marked by elevated levels of erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. This inflammatory cascade directly targets the cartilage and bones, resulting in erosion and damage, unlike the remodeling process seen in osteoarthritis. Distinguishing from viral arthritis. While both rheumatoid arthritis and viral arthritis may present with symmetrical inflammation, their distinction lies in the duration of symptoms. Viral arthritis tends to be self-limiting, resolving within 6 weeks, whereas rheumatoid arthritis and juvenile rheumatoid arthritis are chronic, multi-system diseases with persistent symptoms over longer periods. Understanding these distinctions helps clinicians differentiate between RA and other arthritic conditions, guiding appropriate diagnostic and management strategies. Now let's explore the radiographic findings and joint deformities associated with rheumatoid arthritis and osteoarthritis. Bony erosions. A distinguishing feature of rheumatoid arthritis is the presence of bony erosions, which are visible on radiographic imaging. These erosions result from the inflammatory process, leading to the destruction of cartilage and underlying bone, in stark contrast to the bone remodeling seen in osteoarthritis. Joint deformities. Rheumatoid arthritis often presents with characteristic joint deformities, such as the swan neck deformity and boutonniere deformity. These deformities are a consequence of progressive joint damage and instability induced by the inflammatory process. In contrast, osteoarthritis primarily manifests as Heberden's nodes, which are bony growths at the distal interphalangeal DIP joints and osteophyte formation. Unlike rheumatoid arthritis, osteoarthritis is characterized more by these degenerative changes rather than erosive alterations. Understanding these radiographic findings and joint deformities is pivotal in distinguishing between rheumatoid arthritis and osteoarthritis and guiding appropriate diagnostic and management decisions for patients. Now, let's quickly dive into the relevant autoantibodies and prognostic factors in rheumatoid arthritis. Autoantibodies. The presence of anticyclic citrullonated peptide, anti-CCP antibodies is highly specific for rheumatoid arthritis. Their presence is not only diagnostic but also indicative of a more aggressive disease course and a heightened risk of developing bone erosions, further complicating the prognosis. Rheumatoid nodules. Another important consideration is the presence of rheumatoid nodules, painless subcutaneous growths often found in individuals with rheumatoid arthritis. These nodules are considered an extra-articular manifestation of rheumatoid arthritis and are associated with a poorer prognosis, especially in those with elevated rheumatoid factor titers. Prognostic factors. Several factors, including the presence of rheumatoid factor, anti-CCP antibodies, and the development of bony erosions on radiographic imaging can contribute to a more severe and progressive course of rheumatoid arthritis. Identifying these factors early on allows for a more proactive and aggressive treatment approach to mitigate the impact of the disease. Understanding these autoantibodies and prognostic factors is essential in assessing disease severity and tailoring treatment strategies to optimize outcomes for patients with rheumatoid arthritis. Let's investigate the available treatment strategies tailored for different severity levels of rheumatoid arthritis. For patients with mild rheumatoid arthritis, characterized by morning stiffness exceeding 1 hour and a negative rheumatoid factor, the typical approach involves treatment with non-steroidal anti-inflammatory drugs, NSAIDs, alone. These medications help alleviate symptoms and improve quality of life for individuals with mild disease activity. Moving on to moderate rheumatoid arthritis, the treatment strategy becomes more comprehensive. NSAIDs are often combined with disease-modifying anti-rheumatic drugs, DMARDs, to not only manage symptoms, but also slow down disease progression. This dual approach aims to provide both symptomatic relief and long-term disease control for patients with moderate rheumatoid arthritis. In cases of severe rheumatoid arthritis, characterized by joint subluxation, incapacitating pain, or widespread involvement, a more aggressive treatment regimen is warranted. Alongside NSAIDs and DMARDs, corticosteroids are added to the mix to provide comprehensive disease management and control. This multifaceted approach helps address the complex and debilitating nature of severe rheumatoid arthritis, offering patients the best chance at symptom relief and improved quality of life. By tailoring treatment approaches to the severity of rheumatoid arthritis, healthcare providers can optimize outcomes and enhance the well-being of patients living with this chronic autoimmune condition. Let's dive into the world of disease-modifying anti-rheumatic drugs, DMARDs, and their role in the treatment of rheumatoid arthritis. First up, we have the tumor necrosis factor, TNF inhibitors, such as adalimumab, etanercept, and infliximab. These agents are potent in managing rheumatoid arthritis symptoms but come with considerations. Prior to initiation, screening for latent tuberculosis is crucial due to the risk of reactivation. Additionally, there's a potential for immunosuppression-related complications, emphasizing the need for careful monitoring throughout treatment. Next, we have immunosuppressant DMARDs like azathioprine, methotrexate, and cyclophosphamide. While effective in managing rheumatoid arthritis, these medications require vigilant monitoring of blood counts and liver function to mitigate adverse effects and ensure patient safety. Moving on to other DMARDs, such as sulfasalazine, leflunomide, and chloroquine, each comes with its unique monitoring requirements. This may include liver function tests, folate supplementation, and regular eye exams to detect any potential ocular complications. It's important to note that the selection and dosing of DMARDs are often personalized to each patient's individual metabolic profile and comorbidities. Close monitoring is paramount throughout treatment to optimize efficacy and minimize the risk of adverse effects, ensuring the best possible outcomes for patients with rheumatoid arthritis. Now let's explore the various disease-modifying anti-rheumatic drugs, DMARDs, commonly used in the treatment of rheumatoid arthritis, RA, and the precautions necessary for administration. TNF inhibitors, adalimumab, etanercept, and infliximab, are examples of TNF inhibitors which are highly effective in managing RA symptoms. However, it's important to note that these agents require screening for latent tuberculosis prior to initiation due to their immunosuppressive nature. Additionally, patients may be at risk of immunosuppression-related complications, emphasizing the need for careful monitoring throughout treatment. Immunosuppressant DMARDs, drugs like azathioprine, methotrexate, and cyclophosphamide are classified as immunosuppressant DMARDs and are also utilized in RA management. These medications work by suppressing the immune system to reduce inflammation. However, close monitoring of blood counts and liver function is essential to prevent potential adverse effects and ensure patient safety. Additional DMARDs. In addition to TNF inhibitors and immunosuppressants, there are other DMARDs such as sulfasalazine, leflunomide, and chloroquine. Each of these medications has its own unique monitoring requirements, including liver function tests, folate supplementation, and regular eye exams. These monitoring protocols help healthcare providers assess treatment efficacy and detect any potential complications early on. Understanding the different classes of DMARDs and their monitoring requirements allows healthcare providers to tailor treatment regimens to each patient's specific needs, ultimately optimizing outcomes and improving quality of life for individuals with RA. Now let's shift our focus to juvenile rheumatoid arthritis, JRA, and explore its unique characteristics. Similarities to RA. Juvenile rheumatoid arthritis shares many clinical features and diagnostic criteria with adult-onset rheumatoid arthritis, such as symmetrical joint involvement and the potential for extra-articular manifestations. This similarity aids in the diagnosis and management of the condition across different age groups. Milder presentation. However, compared to adult-onset RA, JRA typically presents milder symptoms. There are fewer severe bony erosions, better cartilage support, and greater joint stability in juvenile cases. Despite this, it's important to recognize that JRA can still significantly impact a child's development and quality of life. Systemic involvement. Within the spectrum of JRA, there's a subtype known as Still's disease. This variant presents with a more systemic involvement, characterized by symptoms like high-grade fever, salmon-colored rash, and the involvement of organs such as the liver, spleen, and serous membranes. Recognizing these systemic manifestations is crucial for timely diagnosis and management. Understanding the unique characteristics of juvenile rheumatoid arthritis allows healthcare providers to tailor treatment approaches to meet the specific needs of pediatric patients, ultimately improving their outcomes and quality of life.